I'm Dr. Matthew Harb. I'm an orthopedic surgeon. I specialize in hip and knee replacement. I wanted to give a special thanks to Sibley Hospital, Johns Hopkins, as well as the Gildenhorn Institute for hosting this talk. So we're going to talk today about advances in knee replacement surgery. If you have any questions or comments during the seminar, you can just put them in the Q&A section and I'll get to them at the end. So with that, we'll go ahead and move forward. So let's first talk about what advances in knee replacement surgery have happened in the last 5 to 10 years. And before we jump into that, we're going to want to talk about what are the goals of knee replacement surgery, what are we trying to accomplish, and how have the advances in the last couple of years helped us to accomplish these goals. So really at the heart of knee replacement surgery, the goals are to reduce pain from the arthritis, decrease swelling, decrease inflammation. We want to restore function. Whenever you have arthritis, you get a stiff knee, you get destruction of the cartilage, you get inflammation. And we really want to restore that function when you lose range of motion. With the stiffness, decreasing range of motion can continue to get worse until we do something and treat the arthritis. And then at the final and very heart of doing a knee replacement surgery, we want to improve your quality of life. And that's why we do this. That's why I do this. I want to get you back to the things that you were doing before you had this terrible arthritis, and whether that's improved mobility or just improve things in your day-to-day life. So the goal is to talk about where we can advance and where we have advanced knee replacement surgery. And so the main areas that we focus on when talking about advances are what can we do to minimize complications that we didn't do in the past. Complications include things like infection, loosening of implants, stiffness after surgery. If you develop patella clunk or develop instability, what can we do to minimize these complications? And we've gotten them to a point where they're all very, very low, and a complication after knee replacement surgery is now almost less than 1%, which is very good. We want to allow for early ambulation. What that means is getting you up, getting you walking as quickly as possible. That's why we're doing this operation, to get you back to your life. So we want you to be up, we want you to be walking, and how can we facilitate doing and getting you back to early walking? With all this comes decreased length of stay in the hospital. In a COVID era, patients don't want to be in the hospital. The other thing is, we know that the longer you stay in the hospital, the higher risk of a complication. So the goal is doing surgery and being minimally invasive, less soft tissue trauma, and doing surgery in a way and using medications in a way that can decrease your overall pain and shorten your length of stay in the hospital. And we've gotten it in some cases to less than 24 hours. Most of the time, I would say on average, a stay is about 24 hours. But even in an outpatient setting where we can send you home 2 to 4 hours after surgery. Decreased pain and narcotics, a lot of this goes into which medications we give you before the surgery, which medications we give you to go home with, using things like spinal anesthesia or blocks. We know that opioids have a lot of different effects, like constipation, like suppressing your breathing. And our goal is to try and minimize the narcotic needs by minimizing your overall pain. A natural feeling knee. So this goes into a little bit of implant design and how things have changed over the years to give you the most kinematically natural feeling knee when you leave that operating room. By doing this, we can use surgical techniques that preserve the muscles, tendons, and ligaments to give you a more natural feeling knee. One of the ligaments called the posterior cruciate ligament, which was sacrificed before. In my operation, I keep this ligament. It gives you something called proprioception. Proprioception is how you feel your knee in space and how your mind tells your body where your knee is and what your knee is doing and what your leg is doing. And so by maintaining the ligaments and not having to take them anymore, we can preserve this proprioception and make your knee feel more natural. Increasing the lifespan of the implants. A lot of this had to do with implant design, especially polyethylene design. The polyethylene is the plastic insert you can see here over on the right of your screen. Previously, we didn't have highly cross-linked polyethylene. Sometimes we put vitamin E in this. The goal is to give a polyethylene that lasts for a very long time. And with newer polyethylene designs, we're seeing these knee replacements last 25 years or even longer. And the goal is to do a knee replacement that lasts your lifetime, where you don't have to go back and have another surgery down the line. And then finally, avoiding transfusions. We know that transfusions after joint replacement come with a higher risk of infections and complications. And so now we almost never transfuse. I never transfuse my joint replacements after a knee replacement because surgical techniques, my blood loss is very minimal, and we use different medications to decrease and minimize blood loss during the surgery. So these are all things we're going to hone in on and talk in a little bit more detail about, and how these things have advanced knee replacement surgery in the past years. Our focus, all these things will take place in the preoperative, intraoperative, and postoperative area. Education has been shown to be incredibly important. Things like preoperative classes or handbooks. We'll dive into the preoperative education and how this goes into improving outcomes. Medications to decrease pain, minimize narcotic usage. Surgical technique being minimally invasive, preserving those muscles, ligaments, and tendons, and we'll dive further into implant design. So I think the key to all of this, and this just goes to show as a testament to the seminar, is that patient education in 2021 is way different than it was 10, 15, 20 years ago. You guys are here listening to the seminar to further your education and know your expectations and know what's out there before you go through with a knee replacement. And I think that's phenomenal. And so I've written a 30-page handbook that I give to all my patients before surgery. I think this handbook is one of the keys to success because I've compiled it over the last 7 years to answer your most commonly asked questions, so that when you go into the operation, you know everything that I'm doing. You know everything that's expected for a normal outcome. And you also know the risks that you're taking. No surgery is without risks, and we've done everything we can to minimize those risks. But I want to detail every step of the process for you, and I think that's something you should know before you go into a total knee replacement, because it's a big operation and there's a lot of preparation that needs to be done. And we know that front-end preparation leads to better outcomes after the surgery. And I think the joint replacement classes have also been an excellent thing to just further answer your questions. But I think this is where, aside from using fancy computers and surgical techniques, I think this has been a huge improvement in setting expectations and improving outcomes after the surgery. Other things that we do now that were not done in the past are pre-op rehabilitation, or you may have heard of prehab. We know that preoperative strength and function of your knee will lead to better strength and function after the surgery. So I think this is crucial. All my patients get preoperative exercises to perform, and they'll go to physical therapy before, meet with the therapist they're going to see after. And this really helps you to improve. Having a knee replacement you should prepare for it like you're preparing to get ready for a marathon or getting ready to take a test. You have to prepare for it because it will lead to a better outcome after. And we know there's many studies that show preoperative range of motion, improved preoperative range of motion leads to improved postoperative range of motion. You're also familiar with the exercises and you can focus on them. You're not having to learn them brand new right after you've had a big operation. And this also helps to set the expectations and goals. And this also kind of falls into that preoperative education category. Something that's been developed kind of over the last 5 to 10 years is what we refer to as ERAS, or enhanced recovery after surgery. We know that rapid recovery after surgery is our goal and what patients want. And this improves the overall patient experience, and patients know what to expect. This ranges from doing things as little as drinking a Gatorade 2 hours before your operation as you're on the way to the hospital. That gives you a boost, helps keep you hydrated, gives you a little bit of energy. So when you come out of that operation, you're ready to start rehabbing right away, get up and walking, get moving. A lot of it goes into the medications we use, giving you things to tone up your bowel and prevent you from being constipated from the medications, not using as many narcotics, and not using things like catheters and using anesthetic medications that will not prevent you from urinating, will not keep you from not urinating, which is something that sometimes narcotic medications can slow everything down, both urination and bowel movement. So making all that regular. doing things like minimally invasive surgery and how we do the surgery. And all this goes into the ERAS protocol. So planning before surgery, reducing the overall stress of the operation, minimizing soft tissue damage during the operation, giving you the appropriate pain medications, which we've done a lot better job than we have in the past, where patients just got over narcotic and over opioid medicated, where they were staying 2 weeks in the hospital, which is just not the right way to do things. So I think that's where a lot of improvement has been made. And these protocols have been tailored both with our hip and knee societies and a combination of the orthopedic surgeons and the anesthesiologists together. And I think we've done a very good job. And most top hospitals and joint replacement programs have implemented this ERAS protocol. Going into more preoperative stuff and anesthesia, I recommend spinal to all my patients. There's good literature on this, and that patients do have improved outcome. There's less blood loss. You're relatively hypotensive, which means your blood pressure doesn't go through the roof like sometimes it does with general anesthesia, which leads to less blood loss overall. We know patients' pain and opioid needs and narcotic needs after the surgery is much less with spinal anesthesia. And we know patients who have spinal anesthesia actually have a much lower and shorter length of stay. So you're up, you're walking sooner, and you're getting out of the hospital sooner. Things I also do for my knee replacements are adductor blocks. This provides some a little bit of anesthesia to the front and medial side of your knee. This really decreases pain after knee replacement surgery and has been excellent for my postoperative patients. At the time after I put all my implants in and I'm ready to close up the knee and everything's in a good position, I'll do something called a periarticular injection. This is a cocktail of numbing medication, which I use to inject around the knee capsule. And this also helps with pain after surgery and gets patients up and moving quicker. So one of the things I mentioned before is that patients no longer need blood transfusions after knee replacement surgery. Previously, 10, 15 years ago, a patient may undergo a knee replacement and their hemoglobin may drop 4 or 5 units. So we use something called tranexamic acid. This is a medication that stabilizes what's called the fibrin clot. You have a clotting cascade, and the fibrin clot is kind of the end of the cascade. And by stabling this clot, it doesn't increase your risk of any deep vein thrombosis or any pulmonary embolism, but it just prevents bleeding in your knee. And with this, we no longer have to transfuse our hip or knee replacement surgery patients. And this has been a game changer as far as the joint replacement world has gone. And on top of that, we are using more minimally invasive techniques. We're using bone sparing techniques. When we cut less bone, we're not as invasive, so there's not as much bleeding. And our surgical times have also gone down significantly from 15, 20 years ago. You can imagine if the knee is open and you're doing an operation for 3 hours, there's a lot more bleeding than if you're just in there for 45 minutes or an hour doing a replacement surgery. So all this has kind of led to decreasing blood transfusions. We know from our hip and knee replacement literature that patients who undergo blood transfusions are at higher risk for infections as well as complications. So this has been very good to avoid. Antibiotic cement. So this has been around for a little while. It's antibiotics that are loaded into the bone cement. So there's 2 types of knee replacements. There's a cemented knee replacement, and there's also a press fit knee replacement. If you have very severe osteoporosis or very poor bone quality, you will get a cemented knee replacement. And antibiotic impregnated bone cement has shown to lower our infection risk, and it's good for patients with poor bone quality. Press fit is not an implant for everyone. It is, and we'll get into press fit and what that means a little bit later in this talk. Improved surgical technique, which I've mentioned a lot. I am there's been 4 main generations of joint replacement surgeons. We've learned from the mistakes of the past, and this was a very different surgery 20, 30 years ago than it is today. We use smaller incisions. Our surgeries are much faster. We are able to preserve things like that posterior cruciate ligament I talked about to provide more natural feeling knees. We're able to better preserve the muscles, the ligaments, and the tendons. For me, I do a plastic surgery closure, so all of my sutures are dissolvable. They're all under the skin. That means patients don't have to get their staples or sutures out in clinic, which can be very painful and discomforting for them. It also means you can follow up with me at 4 weeks instead of having to see me at repeat intervals and deciding whether or not to take sutures out. I use something called a Dermabond glue and tape. It's a skin glue and a skin tape. And we've also figured out ways to improve balance of the knee. So the overall goal of a knee replacement surgery is to come out of the operating room with a knee that's both stable in flexion and extension. And we've perfected these techniques of how to properly balance the knee and do soft tissue releases as needed, and use better implant designs to give you a really stable and well-functioning knee that will last you a long time after you get a knee replacement. And like I've mentioned before, we've really cut down on this operating time. This used to be a 3-hour operation where you'd stay 2 weeks in the hospital, and now it's a 45 to 1 hour operation. 45-minute to 1 hour operation. So I mentioned before a press fit knee replacement. This is a cement, you see here, a cementless knee design. So we've been able to create this 3D porous sprayed titanium, which coats the bottom of our implants and coats the femur, coats the, depending on which implant design you use, the patella you can get it in, and also on the femur. And we know that this has very, very good results, depending on the patient and depending on their bone quality. This allows your bone to actually grow into the implant and avoid having to use bone cement. The good thing about this is there's improved durability. I use this in patients who are under 65 years of age, in most all of them, unless they have some type of osteoporosis or poor bone quality condition. And then even if you're 70 or 75, depending on your bone quality, this is still an option. And usually we can tell that and make a decision in the operating room. But the idea is to give a longer lasting implant to the younger patients who may need a joint replacement. We've also done things like we actually remove less bone with the press fit type implant. So if we have to do a revision down the line, it actually becomes easier, and no longer having to wait for cement to dry, which can take 10 to 15 minutes. So our overall operative time has gotten even shorter with these press fit type cementless knee implants. As I mentioned before, I preserve the posterior cruciate ligament. I think this is great for a natural feeling, more kinematic, better working, better functioning knee. If you look on the right side of your screen, you can see a PS knee, which is a posterior stabilized, and you can see there's that big box cut out of it. So in the past, knee replacements with a PS type design had a large post, and this would prevent the tibia from sliding backwards or the femur from sliding forwards. But we know that we can get by with something called a cruciate retaining or a CR type knee, which you see on the right side of your screen, without having to make this very big box cut that takes the posterior cruciate ligament. This takes less bone, so it's less invasive of an implant. We use these polyethylenes, which I'll talk about in a little bit, that are high molecular weight and highly cross-linked, which provides better longevity as well as a more conforming and more stable design. So I think switching from the PS to a CR knee has been a huge advancement in the last couple of years for knee replacement. Avoiding patella clunk and patella crunch. So this is something that was very common with this PS or posterior stabilized type knee. In this box cut on the right side of your screen, you can see we're looking at the knee from the side, and at the superior, or the top part of the patella, there's this red nodule. So that red nodule was scar tissue that would form at the top of the patella. And when you're bringing the knee from a position of flexion to extension, this nodule would actually get stuck in the box, and it would clunk out. It can also develop scar tissue and do something called patella crunch, which is as you move your knee through range of motion, you hear crunching and grinding. So modernized implants, and especially avoiding the box cut, and how the trochlea, which means the groove on the femoral component, is designed, and the ratios of how these are designed, has actually almost completely eliminated this problem. So patella clunk, which used to be a problem, has been almost eliminated with more advanced knee designs and removed with the with switching to a cruciate retaining type implant. Improved polyethylene, so the wear properties of polyethylene are very good. This was kind of the limiting factor on how long a knee replacement could last. We've impregnated these with vitamin E, which prevents oxidation. Oxidation is basically destruction of the polyethylene, and this happens over time. And the goal is to slow that process and make the polyethylene strong enough to a point where the oxidation doesn't destroy it. And we've seen these knee replacements after they've been cycled on load machines, that they should last up to 25 years, if not even longer. Also the overall design, you can see the conformity here. It has an 8mm anterior lip as well as a highly congruent lateral compartment. There's a medial and lateral compartment to the knee. This helps with a little bit of pivoting of the knee. So your knee is not just a hinge joint. It doesn't just flex and extend. There's also an internal and external rotation component to this knee as you come through range of motion. So this polyethylene liner conforms in such a way that it allows your knee to not only flex and extend and be stable when moving to the front and moving to the back, it also allows it to be very conforming to allow the knee to rotate as it needs to do and roll back, which is the natural kinematics of the knee. So these improved conformity, improved polyethylene designs have really improved overall knee replacements and give you a more natural feeling knee. Computer navigation, or GPS. So we now have these fancy computers that we can hook up to our cut jigs and actually align the knee with the mechanical axis. So a perfectly balanced knee is in line with your mechanical axis. What that means is your mechanical axis is how you bear weight from your hip joint through your knee joint to your ankle joint. And you want that to be a straight line. A lot of the times when you develop arthritis, that line is no longer straight. You may develop a knock-kneed or a bowed-knee deformity. And so we want to restore that line. So computer navigation lines everything up with your hip center, through your knee, through your ankle, and sets our cut guides to allow us to cut in line with the mechanical axis every time. It's very good for revision cases, or if you have a previous femoral nail in there or retained hardware, or you just have a really bad deformity. The computer navigation and GPS, you don't need any CT scans ahead of time. There's no extra pins that go into the bone. So this is good, and one of the techniques that have advanced in the technology sector for knee replacements. We also have intraoperative fluoroscopy. Down at the bottom of the screen, you can see something called a C-arm. We can use this to take x-rays in the operating room. There's software that will load up to this computer and to the screen to help us make sure our alignment is proper and correct during the knee replacement surgery. You can use it for primary knee replacements. You can use it for revision knee replacements. It can be helpful for determining alignment and making sure everything's properly in the right place. And then this is kind of the hot topic, which is robotic assisted surgery. There's a couple different implant companies out there. You may have heard of them: Stryker, DePuy, Smith & Nephew. They're kind of the big players in the robotics world. And what you do with this is you get a CT scan of your knee ahead of time, and you'll put some pins and GPS trackers into the bone. And there's you see the fancy camera on the left. This will align up with the pins in your bone, and then everything will basically align with your mechanical axis. So all of the robotics is just trying to be as precise as possible when aligning things with your mechanical axis. And then you have a robot arm that does something called haptic sensation. That means that it's a saw that the surgeon is controlling, but the robot will make sure that you're cutting in the proper plane. And then on this other screen, you can see there's a computer hooked up. If we need to make any modifications to the computer templated plan, we can do this. And so this is kind of where I think we'll see advancements in the next 5 or 10 years with robotic surgery. And so finally, after the operation's done and we've used all our fancy tools to give you a perfectly natural feeling knee, we will close up the incision. And so even incision closures have been improved. So I use all dissolvable sutures. They're all under the skin. I do a plastic surgery type closure. And I use this thing called Dermabond tape and Dermabond glue. This basically stays on and it will fall off on its own, usually about 3 or 4 weeks after the operation. There's no need for suture removal. I like it, and patients like not having to undergo getting their staples taken out in clinic, which has been nice. Advancements on just the overall surgical aspect and decreasing length of stay. We now have same-day surgery where you can come in, you can get your operation, and you can go home 2 or 4 hours after the operation. The goal is to get you up walking as soon as possible. 1 hour after the operation, they'll get you up walking, and you can go home 3 or 4 hours after the operation. Now, this is not for everyone, but it's kind of where joint replacement is going, and it is an option if you are interested in going home the same day and having an outpatient surgery. So putting it all together, what have we accomplished with these advances, and what were we set out to accomplish, and what will we look forward to the future to improve on as well? And at the bottom line, in the heart of all of this, is we want to improve patient outcomes. We want to lower complication rates, and we want to improve your function. We want to get as much range of motion out of that knee as we can. We want you to have a natural, normal, kinematically aligned, well-functioning knee. And the ultimate goal in all of this, and why we're doing this, is to get you back to your quality of life. And we accomplish this with less invasive procedures, more precise procedures, smarter, longer lasting implants, and faster post-operative surgical recovery. And all of that has led to improvement in the outcomes in the last 10 to 15 years in the knee replacement realm. So I just wanted to thank everyone for attending. You can visit me online at my website. I have great guides, my handbooks online. Even if you're not having surgery with me, I would recommend you read through my knee replacement handbook. It has preoperative exercise, any questions you may have. I also have cartoon videos of knee replacement surgeries on my website. You can follow me on social media. I'm very active on Instagram. I do case posts, and I'll talk about my difficult cases and techniques, as well as Facebook and Twitter. My email is below. If you have any questions, feel free to email me at any time. And my office number is there if you're interested in coming to see me for a knee replacement evaluation. So with that, I will get to some of these questions. So we'll start with Linda's question. The model of the knee replacement looks like it can only move back to front and cannot rotate at all. Is that correct? So I would say that is not correct. So there's a couple different companies out there that will, one company may advertise something called a rotating platform knee replacement. The implant that I use is called the 3D knee. So this allows flexion, extension, and also allows internal and external rotation of the knee. So when you flex down the knee, the tibia actually internally rotates, and you get something called femoral rollback, where the femur actually slides back a little bit. So the way the polyethylene is designed allows for that internal and external rotation of the knee, which is incredibly important to having a natural feeling, well-functioning knee, to recreate and reproduce that natural femoral rollback and natural femoral pivot. The second question from Linda as well. If the bone is not damaged, but only the cartilage, can cartilage be replaced only? Cartilage, once it's damaged, it doesn't have a good blood supply, so it doesn't heal. So this is effectively an overall cartilage replacing procedure. The polyethylene is the cartilage, but we do have to take a little bit of bone, usually about 2 to 8 millimeters of bone underneath that cartilage to replace it. I understand Georgetown Hospital is replacing cartilage. Has it been successful? So if you're very young and you're an athlete, there are procedures called an OATS, or you can do autologous chondrocyte implantation. This is more of a sports medicine procedure. It's usually used in younger, more active patients. And they're using a cartilage plug, usually taken from somewhere else on your body, to replace it. If you have arthritis, this procedure is not a good procedure. It's usually just for an isolated chondral defect in a young patient. So OATS and ACI have been successful in young athletes. Kenneth asks, tell me about using a robot for knee replacement. Is it worth it, or should I allow it? So a robot has the benefits of being able to line up your mechanical axis. In the literature, there's been no difference between using a robot and not using a robot. And using a robot adds a little bit more time than not using the robot to the procedure. So I personally do not use the robot. I would use a GPS navigation in a case where there was a prior retained femoral nail, or if you had a severe deformity, which the GPS navigation and the robot basically do the same thing with lining up everything with your mechanical axis. But overall, they've done many studies and shown no superiority of a robot to just using normal mechanical alignment jigs in patient outcomes. The other thing is you need a slightly larger incision with a robot surgery, because you have to place 2 pins in the femur and 2 pins in the tibia. These pins can be a risk for fracture, which has been reported. And so, and you also need a CT scan before some robotic procedures. So depending on which robot you use. So all of this, I currently do not use the robot because of that. Linda asks, if one has a damaged lumbar spinal disc and that area has compromised nerves affecting the same leg which needs surgery, what other pain procedures would be safest? They can do geniculate blocks around the knee if you have nerve problems. Knee replacement is not going to fix any spinal nerve problems. Deborah asks, what is a partial knee replacement and when do you perform it? So partial knee replacement, there's 3 compartments to the knee: the inside, the outside, and the patellofemoral compartment. Inside is the medial, outside is the lateral, and patellofemoral is right behind the kneecap. So usually when you do a partial knee replacement, the most common area is the inside compartment, or the medial compartment is affected. And so when the patient's at a young age, when they have a severe, not a severe deformity, so they have full range of motion and they really just have bad arthritis in one compartment, it's most commonly the medial compartment. You want to make sure you don't have a flexion contracture. You usually want to have your ACL intact, but the literature is changing on that. And you don't want to have a severe deformity. So one compartment disease and a younger age, you could do a partial knee replacement. Linda asked, what is the difference between full partial knee replacement? When is each recommended? Similar to as before, you know, the total knee replacements are getting very good where they're lasting people's lifetime. So, you know, if you get a partial and it lasts 15 years, you know, that's a good result for a partial, but you're going to most likely need a revision surgery. And, you know, I've had patients who come to me 2-3 years after having their partial knee replacement by another surgeon and saying, doc, my knee's killing me. I need to get this revised. So, you know, the answer isn't always having a partial knee replacement. Sometimes the total will be less complication and last you longer. And also converting a partial knee to a total knee replacement, it's a bigger procedure and the complications are higher with that procedure. Deborah asks, my arthritis is where the kneecap fits onto the knee. I can walk without pain, but cannot do steps. Do I do a total knee replacement or can you do a partial? So it really depends on where the arthritis is. You know, I would have to look at an x-ray. They do have an isolated patellofemoral joint replacement procedure. The indications are very, very rare. It's most likely that if you have arthritis in your patellofemoral groove, that is, so when you go upstairs and downstairs, you do something called you eccentrically load your muscles, your quadricep muscles, which means your quad is pulling the hardest on that patella and really pushing it into the part of the femur called the trochlea, which is the groove on the femur. And so most of the time you also have arthritis in your other compartments. So I would have to see an x-ray to know whether you needed a total or a patellofemoral replacement. How do you handle people? Anonymous asks, how do you handle people who are over 80? I do hip and knee replacements. You know, just because your age is over 80 doesn't mean you're physiologically over 80. I've operated on many people who are 85-year-old, a 90-year-old, and they, you know, they're jumping around like they would be when they're 70. You know, so age is a number, and your physiological characteristics, health, and physiological bone quality are different. I think if you're 80, 85, 90, and you have arthritis and you want to get back to your quality of life, knee replacement is a possibility for you. Linda asks, can one always expect pain in the knee after surgery? You know, it's a big operation. We're doing a major joint reconstruction. We do everything we can to minimize pain. There is a recovery, and usually by about 6 to 8 weeks, I say patients are about 80% recovered after the knee replacement. The goal of doing this surgery is to give you a better quality, better function, and decrease your pain that you had before surgery. Michael asks, how long do all the postoperative numbing, pain reducing injections last post-surgery? I would say anywhere from about 3 to 4 hours after surgery, the medications work for. David asks, would I be able to do aggressive hiking, mountain climbing, and running? So really, you know, I won't say no to that answer. I've many patients who I've done knee replacements on who still hike and do activities. You know, mountain climbing, that's a risk for falling. Anytime you have a risk for trauma to the knee, it depends how aggressive. If you're just scrambling up the mountain without any gear, I would say that's probably okay. If you're using ropes and everything on a mountain, I would say we should probably hold off on the knee replacement. And really running, it's not that you can't run, it's that you're going to decrease the longevity of the implant. So I say a knee replacement is like a car. The more miles you put on it, the quicker it can wear out. So if you plan on running and climbing mountains, I would say hold off on the knee replacement. Let's wait till you feel like you're ready to retire from those things. Lucian says, what are your thoughts about doing both knees at once? It is a possibility. They've had some literature come out saying blood loss and complications are a little bit higher. I like to stage my knees where, you know, if someone wants them both done, I'll do them either anywhere from 3 to 4 or 5 weeks apart from each other, and we'll book them back to back. So I try to, it's not that I can't do them both at once. I just think patients have a better result if you do them staged, which is one after the other. Christina asks, what should your BMI be below for surgery? Also, if you recommend, have you been recommended for 2 knee replacements? Should you do both at once? BMI, I like my patients to be under 40 for BMI. I think that's a good cutoff. There's been literature showing that if you're under 40, complications are much less. Should you do both at once? I like to do them, you know, 4 to 6 weeks apart from the first one, which is simultaneous would be doing them both at once. Staged would be doing them a couple weeks after the other. I like to do them staged. Anonymous asks, is an 87-year-old male too old for a knee replacement? No, you are not. Kay asks, in COVID time, is pre and post-op virtual? So they can do it if you want it virtual. Most of the time I have patients getting home health. So they'll get a physical therapist coming to their house for 2 weeks after the surgery, and then they'll transition to an outpatient surgery center, or they can transition to a telemedicine. They'll transition to they'll do outpatient home PT for 2 weeks after surgery, and then they'll transition to outpatient physical therapy. And the physical therapy offices are using COVID precautions. So they've decreased their number, they've increased space. So it's very safe doing post-op PT depending on the place that you go to do it, but you can do a tele-PT. Martha says, I have serious osteoporosis. Are there special considerations for this diagnosis? I'd use a cemented implant. In worst case scenario, I can add a stem onto the implant, which gives it more stability. I've done knee replacements in very severe osteoporotic people, not a problem. Michael asks, what are the typical time for a successful recovery for a mid-60-year-old who's in relatively good shape and cycles regularly? I would say about 4 to 6 weeks, you'll make 80% of your recovery. Aline asks, how suitable is this for an 80-year-old knee? I would say very suitable if you want to improve your quality of life and you have terrible arthritis, depending on your other medical problems. But I've done plenty of people between 80 and 90 years old. Lauren asks, what do you think about partial? If a doctor recommends one, would you do one? I I've answered this. I think it's for a younger patient. You know, it may not last as long as a total knee. I do recommend robotic assisted. I don't do robotic assisted. I think there's disadvantages of you need a bigger incision, longer operative time, CT scan before, and extra pinholes in the bone. So I don't do it. How do you do with patients who can't take anti-inflammatories? We'll do modified pain regimens. Tylenol is great. Ice is great. Tramadol and a narcotic usually, but we have different medications for different patients who can't take NSAIDs, not uncommon. Can you do sports activity after recovery like skiing? What happens re-recovery at home using stairs? Patients will use stairs in the hospital and do therapy before they leave to make sure they can navigate those. Skiing's intense. It's a really intense activity on the knees. You know, I'm not saying you can't do it after a knee replacement. I would say when you feel like you're getting to the point where, you know, going down the greens or the blues is fine. You know, I would be going down the blacks or the double black diamonds with a knee replacement. Just, you know, the risk of fall and fracturing around the implant is a really big problem. So we don't want what's called a periprosthetic fracture and you falling and messing the knee replacement up. Kevin says, are these protocols used at all centers for advanced orthopedics? So I'm part of Centers for Advanced Orthopedics. My group is orthopedic medicine and surgery. My protocols are my own. Different surgeons use different protocols. I've tailored mine over the last couple of years to do what I think is best and gives my patients the best outcomes. You know, overall, I would say there's a lot of similarities between most joint surgeons that are keeping up with the literature. ES, is there a cutoff age when surgery can or cannot be done? No. You know, as long as you don't have too many medical problems and your diabetes, if your diabetes A1C is less than 8, BMI is less than 40, you know, and you're relatively, you know, you're not wheelchair bound and going to be wheelchair bound after the surgery, you know, age isn't really a number. It's really specific to you. Recovery time, Lydia asks, recovery time, including physical therapy, 6 to 8 weeks, you're about 80% after surgery. Dan says, I had a total knee replacement in 2016. I've been working to get better range of motion since surgery. My range of motion is 90%. How can I get better range of motion? What is now being done to help patients get near total range of motion coming out of surgery? Well, it's just, you know, we have therapists working with you ahead of time, education to know you need to bend. About 3 to 4 months after a knee replacement, you're kind of stuck with what you got, unless you undergo a knee revision surgery. So I think if it was done, you know, 5 years ago, you're probably not going to get much more range of motion out of that knee. Hopefully it's at least 0 to 90. My goal is 0 to 110, 0 to 120, and then patients sometimes exceed that as well. Kevin says, what's the age concern? 75 and I'm anxious. I do plenty of 75-year-olds. And asks, can a knee revision using new techniques be done on a 10-year-old knee replacement? Yes, new techniques can be used on a revision knee replacement. We have special implants for that. That's a more advanced topic. I didn't go into advances in revision knee replacement, but there's been plenty of them in the last 10, 15 years. Robert asks, left knee arthroplasty done 4 years ago, post-op pain from rear of knee around shin to top of foot. Best guess was nerve was nicked. As a result, I'm hesitant to have the other knee done, have techniques improved to minimize or eliminate the risk of that happen. Around the rear of the knee to the shin to your top of the foot, that sounds like a superficial peroneal nerve. You know, I'm nowhere near that nerve. I'm very far away from it. I haven't had a complication with that nerve. So, you know, I don't know if yours was an extra difficult surgery, but that's a very rare complication to have after a knee replacement surgery. And so I wouldn't be afraid to get your other one done. You know, just go to someone who is fellowship trained and that you feel comfortable with. One second, let me get my Bluetooth back on. Next question is, Kay, I have heard about conformis. What is your opinion? You need an extra CT scan to see for conformis knee. It's advertised as a custom implant. Conformis is advertised as a custom implant. It hasn't shown better results. Sometimes if you use that implant, the jigs don't fit as well, so it takes longer operation. I don't do Conformis. I don't want my patients getting extra radiation if they don't need it, and it's not going to improve outcomes. Sheila asks, what can you actually see on MRI? If you need only a torn ligament area of the knee replaced, I mean a partial knee at 80. MRI will show you the cartilage. So X-rays only show the soft tissues. The MRI shows the cartilage and can show if there's arthritis. You don't need an MRI to make a diagnosis to undergo a knee replacement surgery. That can usually be done on X-ray. But if you need more information, you'd go to get an MRI. Hector asks, after the knee replacement operation, how active can one be in leading a healthy lifestyle? I mean, that's the goal, right? The goal of this operation is to get you back to where you were before, get your quality of life up, and have you lead a healthy and happy lifestyle. So, you know, running, I would try and avoid. I would say brisk walking. I have patients who walk 4 or 5 miles on their knee replacements. You know, I recommend low impact stuff like elliptical, bike, water aerobics, swimming. Michael asks, I am 68-year-old bicyclist. How long after knee replacement am I likely to get back on 2 wheels? You know, so we could have you get back on the bike, you know, doing low resistant exercises, even, you know, 2, 3, 4 weeks after the procedure. Biking's great. It's a low impact. You know, I would go low resistance probably for about, you know, 6, 8, 10 weeks after the surgery. And then once you get that range of motion back, start building up your strength after that. Karen says, my mom had a knee replacement 10 years ago at Sibley. She was 74. She stayed in the Renaissance. I'm 65 and have 2 series of gel shots, which is helpful. I know replacements on the horizon. This has been helpful. You know, gel shots are an option. Corticosteroids, the #1 gold standard. Gel shots you may get relief from. It's kind of a last ditch effort, provides some nutrition and some lubrication to the joint to allow you to move it. Some people have relief with it, some people don't. You know, after you've tried injections and gel, the next kind of step is looking at a knee replacement surgery. Linda says, what type of motion can one not do with a knee replacement? It's a little painful. I would say 50% of people, 60% of people probably have a little bit of discomfort with kneeling. It's not that you can't do it. It's that it may become a little discomforting after the procedure just because we go through the front of the knee. That is something that you can work on. The more you kneel, there are kneeling physical therapy exercises to improve kneeling after knee replacement operation. No restrictions. So I just try and avoid high impact activities. So I recommend against running. I would recommend against, you know, serious impact like skiing, you know, like a black or black diamond. And probably the one mentioned earlier, mountain climbing. I think that's a little intense for a knee replacement. You know, but the goal is to get you back to doing your activities without restrictions. And so I don't really put any restrictions on my patients for after knee replacement, just recommendations. Anonymous, I live alone. Would I have assistance at home after surgery? Sometimes we can have set up a home health. Physical therapy will come to your house. It's recommended that you have a care partner or someone to just help you out for a couple days after the surgery. I think it'll be helpful. Sheila says, what do you mean by arthritis? What do you see on an MRI? So arthritis means destruction of cartilage. When the cartilage wears out, it doesn't grow back. It has a bad blood supply. You get bone on bone, you get pain, and eventually you probably need a knee replacement. And we can see cartilage on the MRI. Destruction of that cartilage or thinning on MRI would be consistent with arthritis. We don't need an MRI to make that diagnosis. We can make it on X-ray. Lauren says, although my doctor recommends a partial knee replacement due to arthritis after a medial meniscus clean out 12 years ago, most of my pain's on the lateral side of my knee. Is this common? Any idea why? I feel that a partial replacement won't resolve pain. So Lauren, that's actually a great question. One of the contraindications to doing a medial sided partial knee replacement would be lateral knee pain. So I would say if you're going to get any replacement, get a total. I don't think that the partial knee replacement will resolve the pain that you're having. Anonymous, can you have the surgery if you can't take anti-inflammatories? What are the alternatives? Yes, you can. We have alternatives. A lot of patients I do, they can't take NSAIDs. They have ulcers or kidney problems or have gastric bypass before. So not uncommon. We have other medications we can give you. Christina, what should your BMI be below for surgery? 40 is what's recommended. Part says, how does body weight affect recovery time following total knee replacement? We recommend you get your body weight down. For every pound you lose, it takes about 8 to 10 pounds off that joint. I recommend a BMI under 40. That's based on your height and your weight. It's a formula. Less complications, lower BMI, also less wear and tear on the implant if you want it to last longer. Alan says, do you use a tourniquet to reduce bleeding? Yes, I use a tourniquet. Blood loss is almost minimal to none during my knee replacement surgery. Diane says, question, right hip replaced. Can it be done if one is unable to get under BMI despite earnest attempts? So, you know, from time to time, I will do patients above a BMI 40. You know, it really depends on their overall health status. I want them to show good motivation, but it makes a, you know, and we also have to have a discussion about the risks of surgery and that your risks are higher. And, you know, can there be other things done? Do we have to send you to a dietitian? Do we have to get you into the right exercise program? You know, it depends how high. If your BMI is 50, 55, do you need to see bariatric surgery before, or what can we do and why is this happening? Is something off with your thyroid? Is something off with your endocrine? You know, there is help out there. It's not just all on you to lose that weight. You know, and we set goals, and I will do patients over BMI 40, but it's really on a select patient by patient basis. And I also want them to show good motivation in losing weight. Christina, I can barely walk. I'm 63. I was a dancer moving to Delaware in a couple months. Is it still possible to do my knee replacement? For you to do my knee replacement and have your rehab at home? Yep, just give my office a call. We'll get you set up. I'll see you, and we could probably get you done within the next, you know, 3 to 6 weeks. Before you move, we could get your rehab set up, and if you like your therapist, they can also do telemedicine with you. You know, after you have the surgery and you've done the exercises, you know, by about you know, 4 to 6 weeks, you really know what to expect. And any therapist across the country is trained in a rehabilitation for a knee replacement. Ruth, I've had 2 knee replacements. My right has never been great, and I need a cane to walk. Is it possible to redo the knee? Depends what's wrong. We'd have to work up your knee, see if something's loose, infection, something else going on. You know, why is it the problem? So that requires an in-office exam and diagnostic workup. So it is a possibility. It just depends. There's something really wrong. Diane, will you be presenting a seminar about hip replacements? Yeah, probably a good idea. I think I could definitely give a seminar on advancements in hip replacements. I have an office in Maryland and in Germantown, and then also my main office is in downtown DC. Do you only do surgery at Sibley? No, I also do surgery at 2 surgery centers in Sibley. Where do your patients go for outpatient rehab? So I have a therapist come to the house for 2 weeks, and then you can either, we can give you a list of recommended therapists or any therapist that's convenient and easy for you to get to. Alan says, what do you recommend after surgery to prevent blood clots, and how long should you use these techniques? So I give my patients compression stockings. These help prevent blood clots and swelling. And then I give patients aspirin, baby aspirin, 81 milligrams twice a day. This has been shown very good to prevent blood clots. This is different from blood thinners in the past, which you know, caused a lot of problems with wound breakdowns and infections. And so 81 milligrams of aspirin has been shown to be very safe after knee replacement. And then the best thing you could do to prevent blood clots is get up and move after your surgery. Where do you do the surgeries? I do surgery at Sibley, and as well as an outpatient surgery center. Jennifer Powell, is 49 too young for a knee replacement? No, you know, it really depends on what your x-ray looks like. If your knee is completely destroyed, tricompartmental arthritis, and you're having pain, your quality of life is completely diminished, I would say you could be a candidate for a knee replacement. Lucian, how do you determine if the knee needs to be replaced? X-ray, pain, or both? So the X-ray shows a lot. You know, I've seen patients with terrible X-rays and they don't have any symptoms. I've seen patients with mild X-rays and they have terrible symptoms. So it's a combination of radiographic and clinical workup and how your symptoms are. And Diane, sorry to hear that. My friend had a mortality after a post knee replacement from a PE during COVID epidemic. She's been recovering very well up to that point. I'm fearful now. I'm very sorry to hear that. It's a very incredibly rare complication. You know, it is any type of being immobile, not getting up and moving, having certain risk factors puts you into a higher category for a PE. We do a risk assessment for DVT and PE before. If you fall into a high risk category, we will put you on something a little more potent than just aspirin, but you know, that's very, very rare. I can't say I've had a mortality from a PE after a joint replacement. Anonymous attendee, have you heard of a situation in which most of the pain is on the lateral side of the knee, even if the arthritis is on the medial side? Yes. You know, with medial arthritis, the knee usually collapses into what we call a bow knee position, and it can put stress on the lateral side and lateral ligaments, so that can happen. If you have pain over there, probably good for a total. Sheila, what do you see as arthritis? 1, 2, 3 different kinds of osteoarthritis. There's rheumatoid arthritis, there's post-traumatic arthritis, there's juvenile arthritis, there's osteoarthritis. There's a lot of different arthritises. You know, at the end of the day, if your cartilage is destroyed, you have arthritis. And what is the treatment for that depends on where you are. Christina, can you dance with knee replacements, ballet, or at least ballroom? Pickleball. Pickleball is great. I love it. You know, a lot of my patients play pickleball. Yes, you can dance. You know, you're not going to be doing crazy positions or any jumps through the air, but you can definitely dance after a knee replacement. Sheila, pain, some left permanent pain, what percentage? You know, it depends. It's different. Why are you having permanent pain? I would say most of my patients do very well and are very satisfied after their knee replacement surgery. The goal is doing the surgery to decrease the pain that you're having from the arthritis. It depends. Every patient's different. There's no percentage on this. I would say very low. Rosaldeed, is there a problem if you have high blood pressure and spinal stenosis? No problem. We do knee replacements on patients with this all the time. David Kinney, is it recommended to improve your physical fitness prior to surgery? Yes, it is. Pre-rehabilitation. Elena, how many knee replacements do you do a month? So I've probably done about more than 2,000 knee replacements. It varies, you know, with COVID and everything happened kind of slowing down, probably about anywhere from 30 to 40. Anonymous, I've had a lot of cortisone shots. Some doctors say it's okay to have them every 4 months. Is there a downside to doing this if I'm 57? You know, so I usually only recommend about 3 to 4 cortisone shots. If you get more than that, there is a associated, can thin out your cartilage a little bit. You know, by the time you're on your 3 to 4th shot, it may be time for a knee replacement surgery, unless you don't want one, and you can just keep injecting until you don't want them anymore. Sheila, what percent of people are in permanent pain? I would say very few. Anonymous, what's the experience with medications would not allow me to successfully use pain meds such as Tramadol, Neurontin, Lyrica? What would you use then? Probably Celebrex and Tylenol are great. Ice as well. Anonymous, do you use a nerve block? Yes, I use an adductor canal block and a periarticular injection. Works very well. No, patients don't get permanent nerve damage from this. Where are the outpatient surgery centers? I have one in Mero, one at Mass Ave Surgery Center, and one at in Germantown, Capital Orthopedic Surgery Center that I use. Anonymous, Germantown, DC, where's your second Maryland office and where are your surgery centers? Surgery centers, Mass Ave Surgery Center, Capital Orthopedic Surgery Center. My office is in Germantown and downtown DC. Yes, they are. Shoot me an email if you need more specifics. Anonymous, if one's been using anti-inflammatories for a long time, would they have a risk of bleeding? It's very small. You know, the medications we use really prevent bleeding. I try to get you to stop your anti-inflammatories before surgery. But, you know, most patients with arthritis are on long-term anti-inflammatories, so it's part of the process. It's not abnormal. Alan, I just had a total knee replacement on the right knee, January 13th. Great success. The left knee has to be replaced. Is there an ideal time? No ideal time. I would say give it about 3 to 6 weeks after, and then you can get it done. Anonymous, how long are people usually on heavy drugs? I try to get patients off narcotics by about 2 weeks after surgery. Some people don't take them at all. I've had people just take Tylenol and Celebrex. It's really hard to tell people not to take narcotics. Some people need it. I would say the majority of people need it, but the goal is to wean off as soon as possible. Anonymous, I've told people I can stay home by myself. What do you think of this? Don't want to go to rehab now. You know, they have telemedicine. I do telemedicine office visits. You know, offices are safe. You know, we wipe everything down, everything's social distance, we're all masked. You know, my office is very safe, and we've spent a lot of money on taking the appropriate precautions so patients are safe. But I can do telemedicine. Just call my office and we can set that up. Anonymous. I'm 22 years old. I've had 3 cortisone shots, and I've had my ACL repaired twice. Could I be a candidate? 22 is really young. You know, I've had patients who are 25, 30 years old. Usually they had like a knee dislocation, multi-ligament injury, and they had end-stage bone or bone arthritis. I would try and push your knee replacement off till you're 35, 40 if you can. Not always possible. It's a very, depends on the certain situation. Anonymous, Celebrex doesn't work, then what? Mobic is another option, naproxen. If that doesn't work, we'll have to explore other options. Alan says, thank you so much, very informative, appreciate you talking. Thank you. Shelly says, what are disadvantages of partials? Partials fail early, so total may be a better option. It's patient specific. Shelly says, what about daily walking for 1 hour, for about 1 hour after a replacement? Will it shorten the life of the replacement? No. I have patients who walk 4 to 5 miles. I think it's great. Get out there, move, get strong, get your life back. How long till you can handle stairs at home? Shelly says. So we get you walking the day of surgery, doing stairs. So thank you for all this. This has been great. I've answered, I think, 76 questions. So if you have any questions and you didn't get to ask them or I didn't get to answer them, my email is mharb@cfaortho.com. My office is 202-835-2222. You can find me on my website with good information, or my social media. Feel free to reach out at any time, and I appreciate everyone for attending. This has been excellent. Thank you.